Liver abscesses, huh? You know those infections that kind of just like hang out in your liver?
Yeah.
Well, they can actually be really dangerous. And for us
Yes.
working in medical microbiology, that's definitely something to keep in mind.
Absolutely. And that's precisely why we're doing this deep dive today into pyogenic liver abscesses. We're going to be looking closely at a chapter from the World Health Organization's Aware book. We'll be focusing on the most important practical information for medical microbiologists like yourselves.
Right. This Aware book is all about access, watch, and reserve when it comes to antibiotics, and it's really valuable. This chapter on pyogenic liver abscesses is just full of crucial information about diagnosis, figuring out which microbes are usually the culprits, and the most effective treatment strategies.
Exactly. So let's dive right in. The chapter starts off by defining a pyogenic liver abscess. It describes it as a collection of pus within the liver. Pretty straightforward, right? But what are your thoughts on that as a microbiologist?
Well, honestly, my first thought is always ew, puss. But seriously, it really highlights that we're not just dealing with a simple infection here, right? This
Yeah.
is like a whole, a deep-seated collection of white blood cells, bacteria, and who knows what else. And it's all happening inside this vital organ, the liver. So that definitely raises the stakes.
Yeah, I totally agree. And that leads us to the clinical presentation. The signs that might make you suspect a pyogenic liver abscess. What should we be looking out for?
The chapter points out fever and abdominal pain, particularly in the right upper quadrant where the liver is, as the most common symptoms. But there are also some less obvious things like nausea, vomiting, even jaundice. Now, jaundice isn't something that immediately screams liver abscess to me. Can you explain that connection a bit more?
Sure, jaundice. That yellowing of the skin and eyes is caused by a buildup of bilirubin in the blood. Bilirubin is produced when red blood cells break down, and the liver usually filters it out. But when you have a liver abscess messing with normal liver function, that filtering process can get disrupted, and then you get jaundice. It's a sign that the infection is really having a significant impact.
Okay, that makes sense.
Yeah.
So we have our clinical suspicions, but how do we actually confirm the diagnosis and figure out the best course of action? I'm guessing lab tests are pretty important here.
Definitely. The chapter emphasizes a two-pronged approach, combining microbiology tests with other lab tests that give us a broader view of what's going on. Let's start with the microbiology side. What tests would you prioritize if you suspected a pyogenic liver abscess?
Well, blood cultures are a no-brainer, right? Especially if we can get them before starting any antibiotics. And if it's possible to drain the abscess, getting a sample of that pus for microscopy and culture is like striking gold.
Exactly. We need to know what we're dealing with, so to speak. We got to know who the enemy is and if they have any special weapons like antibiotic resistance. That's why it's so important to get those cultures before starting antibiotics. Why do you think that is?
Well, I imagine if you start antibiotics too soon, you could mask the real culprit, right? Then it becomes much harder to identify the specific bacteria and its resistance profile. We'd be shooting in the dark, maybe using an antibiotic that's not effective, or even worse, contributing to more resistance.
You got it. It's all about getting the right information to fight these infections in a targeted and effective way. Now, beyond the microbiology tests, what other lab results should we be paying attention to?
The chapter mentions checking the white blood cell count, which makes sense given the inflammation that goes along with an abscess. And C-reactive protein, which is another marker of inflammation, can help us assess the severity.
Right. And to figure out how much the liver itself is affected, we'd look at liver function tests. Things like AST, bilirubin, and alkaline phosphatase. These tests give us a glimpse into the health of the liver and how well it's handling the infection.
It's like piecing together a puzzle, isn't it? Using all these different lab results to create a complete picture of the infection and how it's impacting the patient. But I'm guessing lab tests alone aren't enough. We probably need some visual confirmation too, right?
You're absolutely right. Imaging techniques play a vital role in confirming the diagnosis and guiding treatment. What imaging modalities would you consider for a suspected pyogenic liver abscess?
Well, I remember from the chapter that abdominal ultrasound is usually the go-to imaging tool. It's non-invasive, readily available, and gives a clear view of the liver and any abscesses hiding in there.
Exactly. Ultrasound often provides enough information to confirm the diagnosis, but if we need a more detailed look, maybe to check for complications, a CT scan might be necessary.
So we're not just going on gut feelings here. We're using a combination of clinical findings, lab results, and imaging to make a solid diagnosis. But before we move on to treatment, I'm curious about how these infections actually develop. What are the typical pathways that lead to a pyogenic liver abscess?
Now that's where things get really interesting, especially from a microbiological perspective. The chapter goes into the pathophysiology of pyogenic liver abscesses, describing several possible routes of infection. Um, a pyogenic liver abscess can develop when a biliary infection spreads directly to the liver, or when a complicated intra-abdominal infection spreads to the liver through the portal circulation.
So it's like these infections can kind of sneak in through the back door, so to speak, taking advantage of existing connections within the abdominal cavity.
Exactly. And in cases of systemic infection, the bacteria can even travel through the bloodstream and end up in the liver.
From a microbiologist's perspective, which of these pathways is the most challenging to diagnose?
That's a great question. I'd say bloodstream infections can be particularly tricky because the original source of the infection might not be immediately obvious. It's like solving a microbial mystery, tracing the infection back to its origin to make sure we treat it properly.
It sounds like these pyogenic liver abscesses aren't exactly rare either. The chapter mentioned that they're the most common type of visceral abscess, is that right?
That's correct. And that fact alone highlights how relevant they are for medical microbiologists like you. You're on the front lines of identifying and managing these infections.
So who's most at risk here? What factors make someone more likely to develop a pyogenic liver abscess?
Well, statistically speaking, being male puts you at higher risk. And diabetes is another significant risk factor. It seems that impaired glucose control can somehow make the liver more susceptible to these infections.
The chapter also mentioned underlying hepatobiliary or pancreatic diseases as risk factors. Could you explain those a bit more?
Of course. Any condition that compromises the integrity of the biliary system or the pancreas, like malignancy or cirrhosis, can increase the risk of developing a pyogenic liver abscess. It's like having a weak spot in your defenses that bacteria can exploit.
And one of the most concerning things I read about was abscess rupture. That sounds incredibly dangerous. What are the implications of that happening?
Abscess rupture is a serious complication. It can lead to peritonitis, sepsis, even death. That's why prompt diagnosis and treatment are so crucial. We need to intervene before the abscess reaches that critical point.
Okay, let's dive into the microbial world now. What are the usual suspects behind these pyogenic liver abscesses? I'm guessing there's a whole cast of characters involved.
You're absolutely right. The chapter highlights enteric gram-negative bacteria and anaerobes as the most frequent culprits. We're talking about bacteria like Escherichia coli, Klebsiella pneumonia, and species from the Bacteroides fragilis group. And often it's not just one type of bacteria, but a mix, making the infection polymicrobial.
So it's like a microbial party in there, but not the fun kind.
Exactly. And to make matters more complex, we're seeing a rise in multi-drug-resistant strains involved in these infections. That's where your expertise as a microbiologist really comes into play. Identifying these resistant strains and guiding antibiotic selection is critical.
Speaking of specific bacteria, the chapter mentioned a hypervirulent strain of Klebsiella pneumonia. Is that something we should be particularly concerned about?
It is, particularly in Asia, where this strain is becoming increasingly prevalent. It's known for causing more severe infections, even in otherwise healthy individuals, and it can spread rapidly. So awareness and vigilance are key, especially for microbiologists working in regions where this strain is common.
And then there's Burkholderia pseudomallei, another gram-negative bacterium mentioned in the chapter. What makes it stand out from the crowd?
Burkholderia pseudomallei is unique because it's found in soil and water, primarily in Southeast Asia and Northern Australia. It can be acquired through various routes, including inhalation, ingestion, or even through cuts and wounds. So travel history is an important clue. If a patient with a suspected liver abscess has recently been to these regions, Burkholderia pseudomallei should be on our radar.
We also can't forget about Entamoeba histolytica, the parasite that can also cause liver abscesses. I'm guessing its presence changes the treatment approach quite a bit.
Absolutely. While bacterial abscesses are treated with antibiotics, amoebic abscesses require a different approach. Metronidazole is the mainstay of treatment for Entamoeba histolytica infections, typically followed by paramomycin to eliminate any lingering parasites in the colon.
So knowing the culprit is essential. But once we've identified the cause of the abscess, what's the game plan for treatment? The chapter mentioned a two-pronged approach.
You're referring to source control and antibiotic therapy. Those are the two pillars of treatment for pyogenic liver abscesses. Source control usually involves draining the abscess. This helps eliminate the source of infection, reduces the bacterial load, and can also provide a sample for culture and sensitivity testing.
So we're killing two birds with one stone, treating the infection and gathering crucial information to guide further treatment.
Exactly. And when it comes to antibiotics, The chapter provides specific recommendations based on the severity of the infection and the suspected or confirmed pathogens.
Let's talk about those antibiotic recommendations. What are the preferred choices for mild and severe cases?
For mild cases, amoxicillin clavulanate is often a good first-line option. It provides broad-spectrum coverage against many of the common culprits. Combinations like cefotaxime or ceftriaxone with metronidazole are also frequently used, especially when anaerobic bacteria are suspected.
And what about severe cases? Do we step up the antibiotic firepower?
We do. For severe cases, we might opt for broader spectrum antibiotics like piperacillin tazobactam or meropenem. These antibiotics can target a wider range of bacteria, including those that are more resistant to common treatments.
The chapter also provides detailed information on dosages and duration of treatment. Could you give us a glimpse into that?
Of course. For example, for adults with a mild pyogenic liver abscess, the recommended dosage of amoxicillin clavulanate is either 1 gram plus 200 milligrams intravenously every 8 hours or 875 milligrams plus 125 milligrams orally every 8 hours. For children, the dosing is weight-based, and the chapter provides specific recommendations for different age groups.
But what about the duration of treatment? Is it a short course, or do these infections require a longer haul?
Treatment duration is typically quite lengthy, often at least 4 weeks, and sometimes even months. It's essential to monitor the patient's progress closely with follow-up imaging to ensure that the abscess is resolving and adjust the treatment duration accordingly. Remember, we're aiming for complete eradication of the infection to prevent recurrence.
It sounds like managing these infections requires a combination of clinical acumen, microbiological expertise, and a good dose of patience.
I completely agree. It's a team effort, and your role as a medical microbiologist is absolutely critical. But before we wrap up our deep dive, I'd like to shift gears a bit and put your knowledge to the test. Are you up for a little quiz?
I always love a good challenge. Bring on those exam questions.
All right, get ready to put on your thinking caps, folks. It's quiz time. I've got 5 challenging questions to test your knowledge on pyogenic liver abscesses.
Awesome. Let's see what stuck with you from our deep dive today. Hit us with the first question.
Okay, here we go. Which of these is not a typical symptom you'd see in a patient with a pyogenic liver abscess? Is it A, fever, B, pain in the right upper quadrant, C, cough, or D, jaundice?
Tricky. Give everyone a moment to think about that one.
All right, time's up. What's the correct answer?
The answer is C, cough. A cough might pop up in some rare cases, maybe due to complications or the infection spreading, but it's not a classic sign of a pyogenic liver abscess.
Exactly. We know fever and right upper quadrant pain are super common given where the liver is and all the inflammation going on.
And we talked about how jaundice can happen when that abscess messes with the liver's ability to process bilirubin. So yeah, a cough definitely stands out as the least likely symptom here.
All right, question number 2. Which imaging technique is usually the first choice for confirming a pyogenic liver abscess? A, chest x-ray, B, abdominal ultrasound, C, MRI, or D, colonoscopy?
Keep in mind what we're actually trying to see here, an abscess inside the liver.
And remember, we're looking for a test that's easy to get and not too expensive for that initial diagnosis.
All right, what's the answer?
It's B, abdominal ultrasound. It's non-invasive, available pretty much everywhere, and gives a great picture of the liver and any abscesses lurking around in there.
Okay, on to question 3. Which of these is not a common pathogen causing those pyogenic liver abscesses? Is it A, Staphylococcus aureus, B, Klebsiella pneumonia, C, Entamoeba histolytica, or D, Mycobacterium tuberculosis?
Take a trip back through that microbial landscape we talked about earlier.
We know Klebsiella pneumonia, especially that hypervirulent strain, is a big worry, especially in some parts of the world.
And let's not forget about Entamoeba histolytica, that little parasite that can also cause liver abscesses. Makes things a bit more complicated, huh?
For sure. So what's the answer?
The answer is A, Staphylococcus aureus. While Staphylococcus aureus can cause abscesses elsewhere in the body, it's not as common a culprit in the liver as the other options.
All right, question number 4. What's a crucial part of source control when you're managing a pyogenic liver abscess? A, giving pain meds, B, IV fluids, C, draining that abscess, or D, isolating the patient?
Think back to what we said about not just treating the infection, but also tackling that root cause.
And remember, source control is all about actually removing that infected material so it doesn't spread and cause even more trouble.
Exactly. What do you think?
The answer is C, draining the abscess. That lets us get rid of the pus, reduce how much bacteria is in there, and snag a sample to figure out which antibiotics will actually work best.
Last but not least, question number 5. Which antibiotic combo would be best for a severe pyogenic liver abscess, assuming there are a lot of ESBL-producing bacteria in your area? A, amoxicillin and clavulanate, B, ciftriaxone and metronidazole, C, ciprofloxacin and metronidazole, or D, piperacillin tazobactam.
This one really makes you think about how bad the infection is and what those local resistance patterns look like.
Remember, those ESBL-producing bacteria can resist a lot of the usual antibiotics. We need a combo that's strong enough to actually take them down.
All right, what's the answer?
It's D, piperacillin tazobactam. This combo's got broad coverage, including activity against ESBL-producing bacteria, which makes it a solid choice for tough cases where resistance is a concern.
And there you have it. 5 questions down.
Well,
hopefully everyone's brains are feeling a bit more full of pyogenic liver abscess knowledge now.
for sure. We've covered so much today, from what these infections look like and which microbes are usually involved to how we diagnose them, treat them, and all the importance of source control and antibiotic stewardship.
It's been a great deep dive, but we're actually running out of time.
Ah, bummer. But before we go, I do want to leave everyone with something to ponder. With antibiotic resistance becoming more and more common, what strategies can you, as medical microbiologists, use to make sure we can still treat those pyogenic liver abscesses effectively in the future?
That's a really good question to think about. It's been fantastic having you on the deep dive, and thanks to all our listeners for joining us.
We've covered a lot of ground today, from how those pyogenic liver abscesses present themselves to the microbes that are usually involved. We talked about how to diagnose them, the best ways to treat them, and of course, the super important roles of source control and antibiotic stewardship.
Yeah, it's been a really informative deep dive, but we're actually running a little short on time today.
Oh, that's a shame. But before we wrap things up, I do want to leave everyone with a little something to think about. With antibiotic resistance on the rise, what can you, as medical microbiologists, do to ensure we can still effectively treat those pyogenic liver abscesses down the road?
That's a really important question to consider. So it's been fantastic having you on the deep dive. And a huge thanks to all our listeners for joining us. We'll see you next time.